Welcome to Doc Talk. I'm your host, Mark Houston. As we celebrate the best of 2025 this month, we're revisiting some of our most informative and popular episodes from the past year. This week is episode 151, Trauma Surgery and Emergency Medicine with Dr. Leslie Van Dyne. As a trauma surgeon and critical care specialist at Rapid City Hospital, Dr. Van Dyne shares her unique perspective on caring for patients in a rural area that is known for outdoor adventure and seasonal risks. She explains the differences between trauma surgery and emergency medicine, discusses caring for critical patients in the ICU, and relates how activities like ATV riding, horseback riding, and summer tourism impact the trauma cases she sees. Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. I am Mark Houston, and on this episode, we're going to talk with Dr. Leslie Van Dyne, a general surgeon who specializes in trauma care at Monument Health Rapid City Hospital. She also serves as the medical director of general surgery. Dr. Van Dyne treats patients with critical injuries and illnesses, often in quite high-pressure emergency situations. Today, we're going to learn more about her background, what it means to be a trauma surgeon, and what it's like caring for some of the hospital's sickest and most complex patients. So, welcome, Dr. Van Dyne. I'm glad you did this.
Yeah, thank you.
You bet.
Thanks for having me.
Now, you're local, right? I mean, you're state local, let's put it that way.
Yep. I'm from the east side.
Okay,
actually,
that's fine. Well,
I know. But I came to the west side, best side, about 3 years ago.
Okay.
My house is right next to near here. So,
really?
Yeah, we enjoy Rapid.
What drew you out here then?
Oh, the east side. I was in a 48-mile bubble for the vast majority of my life. Grew up in Valley Springs and then undergrad in Vermilion and med school in Vermilion and loved it, but it's very flat, just kind of a change of scenery while still being around the same type of people and community. And it's a lot closer to my family than Ohio, where we were before this.
Wow. Yeah. Okay. So, I mean, and that has to play a big part in it. Anytime you can be closer to family is nice.
Yes.
For sure. But what drew you to this specific type of surgery? Because we've had some other trauma doctors on this podcast before, and I am fascinated by what you guys do, because to me, it's the most high pressure, quick thinking surgery that has to be done. What drew you to this? Why this one?
Trauma, and actually, trauma is combined frequently with what's called acute care surgery.
Yeah.
So we are, or ACS for short, we are ACS trauma surgeons, and it's a branch of surgery that's kind of developed more recently. Surgeons of yesteryear would do elective cases and things like that, but would also be required to cover the emergency room and whatnot. But now it's branched off to its own field, and this field in particular is fun because you do have to think on your feet a lot. You never know what's going to come through the door, which has the good and the bad that goes along with it. So there's never a dull day. I also enjoy that we meet people from everywhere. We have a very broad patient population. So sometimes it's little kids, sometimes it's elderly patients. We have visitors from all over the world who come through. So it's very variable, and it's always a surprise. And it's usually pretty, not always intense. I mean, there's your standard, somebody had a fall or broke their leg, and those those are pretty run of the mill. But you never know what you're going to get.
Well, is it when you compare it to we get the TV medical dramas all the time. People love watching them, of course. But what's the reality like when it comes to that? Like a normal day for you is what?
Depends what time of year.
Okay, I'm sure.
Let's see. So this past week, summer trauma season is upon us. We've gotten some motorcycle accidents. Usually the majority of traumas come in after hours, and I work during the days predominantly, but we get just as much of the acute care stuff, so perforated ulcers or colons or bowel obstructions, gallbladders, appendixes, the kind of emergent surgery things that aren't trauma related. Those are probably what fill most of the daytime and kind of keep us busy.
Are you, since you said you've been here 3 years then, are you on when it's rally time?
Yep, I'm on rally.
Okay.
I've been on rally every week, and I'm on it. And I make the schedule, so I can't complain. But I am on rally week again this year.
That has to be exciting, not in a positive way for the people coming in, obviously, but for you guys, it has to be.
It is, and I think one of my favorite parts about Rally is the hospital, the whole culture changes. They stop doing elective surgeries so everybody can focus on the influx in the population. And I will meet people we had a gentleman from Italy who was here. We get people from all over the country, their family and friends. It's unfortunate that they have a traumatic episode, which brings them into Monument, but at the same time, I get to learn about where they're from and learn about their families and enjoy their accents. And it's an interesting population.
Well, that's what's, you keep saying you get to meet them. And I mean, you do, obviously, but it's not like, well, we're going out for drinks, we're going to meet. You're meeting them on a moment or in time when it quite possibly is the worst day that they're having, right? I mean, mentally, how do you prepare for that? I do try to put in perspective, if this were my family member or if I were hurt, what would I be worried about? What would be, on my mind or comforting to me? And I try to relay that to them because I know it's hard being in an area you're not familiar with, let alone a situation you're not. And so trying to, I guess, give them some reassurance, but just keeping perspective. Sometimes I think in the medical field, it's easy to treat an injury pattern or whatnot rather than a person, but just trying to remember that they have this specific situation or scenario that they're coming in with. So when something like that happens, let's say you have somebody come in for a motorcycle accident, what happens the moment they walk through those doors? What is it like you see on television or the movies? Is it similar to that? Give people an idea of what happens.
It sure can be.
Can it?
Yeah, there's different types of trauma. So an activation, we call it, is either a level 1 or a level 2 trauma. Level 1 is a higher acuity, and there's certain criteria that have to be met for a person to be a level 1.
Yeah.
So if it's, let's say somebody's at a stoplight and their motorcycle tips over and breaks their ankle, they would come in through the ER just like anybody else, and that would be more of a trauma consultation where you see them in a room, you work them up. On the other end of the spectrum, if somebody has a terrible accident and they're not responsive or have a breathing tube in place, then they would be a level 1 activation. They come in emergently with the emergency squad into one of the trauma bays. And those can turn into, like the movies, pretty dramatic and eventful. Fortunately, that's not the norm. We'll get a few a week, I would say, but
that
it's
still
not
seems
every activation.
High, though. Is it for our area?
Our hospital is a very unique bubble. There are 2 trauma centers in Sioux Falls, for example, but they've got Minneapolis nearby. Omaha's not far. Out here, we're like the only place. So we cover a lot of western Wyoming, kind of northern Nebraska, the middle of the state, everything west of the Missouri, and parts of, we don't go too much from North Dakota, but our patients are coming from very rural or remote areas, or, a lot of traumas do come from the reservations.
Sure.
And so they are being flown in, but the volume that we get compared to most trauma centers is very high just because there's nobody else around.
Well, and that must be, as somebody who enjoys what you do, again, that has to be kind of exciting because, you are getting almost everything that happens, and we are in that bubble here. But that also has to be super reassuring for people that are hearing this podcast right now and that live around this area, knowing that should something happen, we have the ability here in Rapid City to take care of this. You don't have to go. I mean, what instance would you need to fly somebody out of Rapid City?
And I think, to your point, the vast majority, I would say 98% of patients we keep here, we have specialists. And to be a level 2 trauma center, which we are recognized by the College of Surgeons, you have to meet certain criteria.
Now, what does that mean, level 2? Okay.
So a level 2 doesn't mean we don't get the higher acuity traumas. It's the main differences between a level 2 and a level 1 trauma center. One of them are things like in-house neurosurgery. You have a neurosurgeon in the hospital 24/7. That being said, our neurosurgeons have, I think, like a 30-minute response time, and they all live around here.
Wow.
So it's not like they're a couple hours away. They're here, and they're very involved. They're just not in the hospital like we are. And then also the amount of research that your hospital puts out. So there's some fine criteria you have to meet to be a level 1, but level 2s are much more common and doesn't mean we don't have the capability to treat this patients that a level 1 can. It's just we don't have some of the other criteria.
Oh, I see. So, I mean, it's close. Let's put it that way.
Yeah. And I mean, I trained in Cleveland, which is a very busy level 1 trauma center. And I would say then the volume there is higher, but the acuity or severity of the traumas we get here are right on par with some of the big inner city stuff.
What type of is the summer the worst for us when we become the biggest idiots and we end up in the emergency room? I mean, because we have lots of winter activities here.
Yeah.
You know, the skiing and the snowmobiling and all of the stuff we can do up in the hills. The hills are a beautiful place to visit and hang out. We love living here. It's one of the reasons. But man, they can be dangerous for sure, all year round. What do you find the busiest?
Definitely
Summer.
Oh yeah, summer with the tourists, with the rally. We get a lot of ATVs. I used to think ATVs looked fun. I don't know if I'll ever own one. A lot of ATV rollovers, a lot of horse accidents. You know, our farmers and ranchers, especially out in the rural areas, working, you know, accidents there. But a lot of motorcycles, some rock climbing stuff, and then the winter with the crummy weather, we get more car accidents and kind of blunt traumas.
I didn't hear you say the word buffalo in there.
We haven't had any bison accidents recently, since I've been here at least.
Yeah.
But I've heard that they're things. Yeah.
They totally are. Every year we have to, you know, you've seen the shirts and the banners that say, you know, don't pet the fluffy cows, which is very, very true.
Yeah.
So are there misconceptions that people have about what you do that you wouldn't mind clearing up?
Yeah, no, thanks for asking.
Yeah.
And I don't take personal offense by any
No,
means
of course
when people
not.
ask this, but I think people, when they hear trauma surgery, they almost think of it as synonymous with an emergency room doctor, and they're very different fields. So emergency room medicine is a residency after medical school that is completely different from surgery. So general surgery is, 5 years. I did a prelim year, so I did 6 years of that, and then but we do go to the emergency room and we respond to trauma. So do emergency room doctors. We're both in the trauma bay if an activation comes in.
Okay.
But we stay out of the emergency room as much as we can. So we're also see consults on the floor. We also see general surgery things outside of trauma. Again, the appendixes, the gallbladder, stuff like that, and floor consultations, and we're in the OR. So we're not just in the emergency room. We're all over the hospital.
Okay. And another aspect that I kind of mentioned in the introduction here, something that you do, is you care for critically ill patients in the ICU. What's a day like in the ICU?
And the ICU care part of it, you asked earlier kind of why I got into this.
Yes.
So trauma critical care is a fellowship, and I did a year of that in Cleveland, but I got into it more for the critical care than the trauma, to be honest. And so for whatever reason, those two are tied together. But the reason I pursued that fellowship, I really enjoy sick people. I know that sounds kind of messed up, but they're very complex, and there are a lot of moving parts. And I tell my medical students, there's two types of general surgeons, the ones who, and I guess it's a spectrum, but the ones who just want to operate, and that's fine. That's an important part of healthcare.
Of course.
But one thing I really love about general surgery is I can do as much internal medicine or medical management as I want. And when I feel like I've reached a spot that I may not be, somebody else could do it better than me, that's when I can call an internal medicine doc to help with management of diabetes, or call a cardiologist to help manage atrial fibrillation. But if it's, kind of run of the mill, I can do all that kind of stuff. And critical care fellowship gave me extra training and practice in that. So it kind of gives you I like the whole body picture that it kind of provides, because I think if I can, and I joke with my colleagues, I love micromanaging and I love tinkering, which is what the ICU is, we can do better with that glucose, or what's their volume status? Maybe we could and so it just kind of keeps it organized. You think about every organ system within the body, and I think really helps optimize patients' outcomes. So I really like the ICU portion. And to your point, so we have a wonderful ICU team at Monument. I love those colleagues too. They're and every hospital system is different, but how Monument is set up is the majority of their intensivists, we call them, have internal medicine, pulmonology background, and that's a whole other discussion how you can do ICU care, but most of them are internists, pulmonologists by training, and then there's a surgery branch, which is the route I took, but we co-manage patients quite a bit together, and they are wonderful. They let me play in the ICU as much as I want, but at the same time, if I'm tied up in the operating room or in the trauma bay, sometimes you need eyes in the ICU, and they'll cover me, and they're very collegial, and I love working with them. But some of our patient census list on our trauma team will have general surgery patients. Let's say they had bad diverticulitis and they have what we call sepsis, where your blood pressure is low and you're very, very sick from it. Our census will be a mix of those patients, maybe a trauma patient who's got a bunch of stuff going on or is on a breathing machine. I would say we'll have 5 to 10 ICU patients, 10's on the high side, and then the rest of our census will be what we call floor patients or patients not in the ICU. So there's a few higher acuity patients that I get to see and work with every day, and then when they graduate from the ICU to the regular floor, I continue to follow them till they discharge.
Well, all I can think of hearing you talk about this, this has to be an emotional job, though, to do as well, because you're seeing trauma and you're seeing people that are at their absolute sickest. And honestly, some may not make it. How do you handle that?
That part is kind of rough.
I can't imagine.
And there is, I will say great things about my medical school, USD's and experience there. You know, you get palliative care training, you get, and in my residency, you know, education about how to approach those hard conversations. But there's no good way to do it. There's nothing fun about it. And you're right. You're usually the person who's breaking devastating or terrible, or can be, you know, devastating or terrible news to family members. And the thing about trauma is a lot of our patients are completely healthy. They're fine. They're out enjoying the day on their motorcycle, doing what they love. And then the family gets a call that something bad happened and they have no idea what happened, you know, and it's so emergent. You don't have the mental time to kind of think or plan, unlike somebody who maybe has a chronic illness and has had time to say their goodbyes and come to terms. So when you're delivering that news, it can be very difficult. But we also have, to each their own, I think the spiritual or chaplain service that our hospital has, and they're very, you know, they're wonderful, and I don't think I could do a lot of my job without their support too.
Right.
And you know, it's trying to keep the perspective of, you know, you got to keep your stuff together.
Yeah.
So to answer their questions, but it can be hard.
Oh boy. Are there moments that stick with you? I mean, you can't obviously name names or anything, but are there moments you've had in these instances that have really been that you think back on? Yeah,
and some of them I would classify them all as emotional. Some are happy emotional, some are very sad emotional, and I can think of a patient a couple years ago. I was just reminiscing about her with one of my our nurse practitioners, but she was just an amazing woman. She lived around here in the hills and had been here for forever, and she had a bad cancer diagnosis. And when she came in with a perforation or a hole in her bowels, and she was so memorable in that she was comfortable with her spirituality, with her family, with where she was at with life, and she said, "No, I'm okay to go." And I was more sad and tearful about her leaving this world than she was. She's like, "No, it's okay," you know. And I remember holding her hand and being with her. She'll be with me.
Yeah. Well, I can't. Yeah. I mean, you must have. There must just be countless stories like that for sure. Do you have? Okay, this will be kind of a hard right turn. Do you have a favorite surgery you like to do? I love
an open hernia repair. We call them ventral. And because, you know, minimally invasive surgery is great. The laparoscopic, robotic, patients have less pain postoperatively, you know, slight decreased risk of complications. So we, by and large, have moved a lot of our hernia repairs to robotic or laparoscopic.
Yeah.
But sometimes you got to do it the way we used to do all of our surgeries with a big incision, and it's not that I would ever compare surgery to arts and crafts, but sometimes it is.
Well, to you guys, though, it is that.
You know, and to my quilters or sewers out there, it's like sewing on a patch, you know? And so.
I love that.
Yeah, no, I don't know what it is about them, but it's when somebody's got a hole or a hernia in their abdominal wall, you push everything back on the inside where it's supposed to go, and then you just patch it shut.
My goodness. Do you get to work a lot with the robotic side of things?
Yeah.
Do you have a favorite surgery that you do with those?
Oh, I don't know if there's a favorite.
Right.
Love a good perfed ulcer. We do, by far, the most common surgery we do is gallbladder surgery. So we'll take out, I don't even know how many gallbladders a week. And everybody does them a little different. I use the robot when I can for mine. It just helps with visualization. I get to sit down, you know, things like that.
Well, what's the training like on that? I mean, was it a lot of extra training to get ready for the robots?
Not necessarily. My generation of surgeons, maybe even a couple years before me, was the transition. So the chiefs 5 years before I graduated from residency, they wouldn't have gotten any or very little, I would say, robotic experience. But my generation trained on it pretty frequently. So, and now it's shifted so much that graduating residents are so familiar with the robot that they can't do we call it straight stick laparoscopy, where you're essentially using long chopsticks to do laparoscopic surgery. And the robot is wonderful. I mean, you get wrist dexterity, it's 3D visualization, you can zoom in and zoom out. You're not counting on no offense, medical students, but you're not counting on a medical student to hold the camera.
Right, of course.
So the amount of control, comfort, and dexterity that you have with the robot is unparalleled, and new graduating residents are so reliant on that they can't do the old laparoscopic stuff. So, and when I came to Monument, I graduated with my robot certification from residency, but Monument did require that you go through all the things and get the certificates and do the stuff. So I did it. I got to do it twice. Yeah.
Are you good at video games?
No. Well, maybe Super Nintendo, but yeah.
Because dexterity-wise, you must be fantastic.
And it's interesting when you do the robot training, you practice on it is a computer game. It's not a real human or anything.
Right.
It's a module. You're looking through the screen, and it's like a ring pass. You move a ring, don't touch the wire. So it is essentially video games, and the new robot that's coming out. It's pretty wild.
Wait, what's the new one? I want to know what the new robot is.
Dr. Hope might have more to clarify on that, but it's got a phone charger built into it, so that's all I can say about that. I think
that's all they need, honestly.
That's all we need.
So if you had any advice to give to people that wanted to get into this field, what have you learned that you would love to pass on to new med students that are looking to get into this?
I think it's more so, I think, being able to identify who might like this field, because I think medical students, there's so much that you're trying to learn in medical school. It can be hard to sort out, what do I actually want to do, or they think they know what they want to do, but they don't know what they want to do. But just knowing what acute care surgery is and how, if it's a good fit for them, I guess. And I guess the field of surgery too has gotten more competitive. So if you know you want to do surgery, get involved early, make sure you're getting in the ORs, spending the extra time. First person in the building, last one out. We tell good medical students.
Right.
So.
Did you know this is what you wanted to do though when you started medical school? Did you?
I guess I figured it out maybe my second or third year.
Why did you pick medical school to begin with?
Oh, that I knew I wanted to do for pretty much ever. Yeah.
Right.
My grandpa, he was a true general practitioner in Bowdle, South Dakota.
Yeah. Absolutely.
And he was actually from the Philippines. He had 5 kids back in the Philippines and a wife, and he came here to practice and was able to bring them over. And so they went from the Philippines to Bowdle in the middle of winter. And there's actually Polaroids. My mom's wearing like this shirt and she just looks lost.
Like,
what is this place? Just with growing up with him as a role model, again, a family med doc who delivered babies, who took out appendixes, who set fractures. There's not really people who do that much anymore. But just watching him as I grew up, and a lot of my family's in the medical field too. My dad,
awesome.
Brother, sister-in-law, they're all nurses, so we have a very medicine-heavy family, and it's just always something I've been around and knew I wanted to do.
Okay. How often do you get back to the Philippines? Do you get to go?
I've been once. I went once after residency.
All right.
And for a couple of weeks. It was pretty cool.
Where would your grandfather have recommended? Because it's one place I've always wanted to visit. I haven't been there yet. I would love to go.
My mom she's from it's called Batangas. It's like south of Manila.
Okay.
And it was very cool. And when we went back, they have a house there still. And so it was a kind of behind the scenes Philippines tour where you got to see the actual the real life.
Awesome.
Yeah, but some of the resorts I saw also looked very nice. So I'd like to go back sometime.
No, they should just Airbnb that place that they have there right now is what they should do. Start making some money off. That'd be fantastic. Well, Dr. Leslie Van Dyne, it's been a lot of fun talking to you. I'm so glad you came in and did this for sure. And I'd love to sit down with you again someday and, I don't know, get into more specific things that you'd like to talk about now that we kind of have an overview of what you've done, what you do here in Rapid City. I would like to, whatever, especially, I guess, the hernia surgery. I guess we're really going to have to drill down on that because I need to know more about quilting and how it ties into all this for sure. But thank you for coming in and talking. I appreciate it.
Yeah, thank you for having me.